The cutting-edge technology behind Inventor MD's AbClo abdominal wall closure system makes it the choice for open abdominal delayed fascial closure, resulting in statistically better patient outcomes. AbClo Abdominal is the essential appliance for supporting and stabilizing the abdominal wall after incision or trauma, preventing lateral retraction of the abdominal wall fascia, preventing loss of domain, avoiding abdominal fascia damage, and facilitating primary closure of the abdominal wall fascia. AbClo Abdominal is specifically designed to gradually reapproximate the abdominal wall fascia and restore the linea alba. The abdomen is left open for three main reasons: anatomical, physiological, and logistical. The laparotomy incision creates anatomical considerations that affect post-operative treatment. Anatomical reasons for maintaining the open abdomen include the wound edges no longer meeting due to edematous swelling of the viscera, traumatic soft tissue loss of the abdominal wall, or intra-abdominal hypertension leading to abdominal compartment syndrome. The abdomen may be left open for physiological reasons, such as systemic patient complications that require time to resolve, and a bailout approach to stabilize physiological status. Finally, the open abdomen may be maintained for logistical considerations such as allowing for further internal surgery or facilitating a second look before closure. Proper functioning of the anterior abdominal wall is maintained through the action of several distinct muscles, including the external oblique muscles, which allow trunk flexion and contralateral rotation, the internal oblique muscles that facilitate flexion and ipsilateral rotation, and the transversus abdominis muscles that permit side-to-side rotation. The combined action of these three muscles allow the trunk to twist and bend from side to side, with the rectus abdominis muscles causing flexion. In addition to trunk mobility, these abdominal muscles stabilize the trunk, assist in respiration, and maintain abdominal pressure. And with their broad insertion points, provide optimal distribution of this pressure. Muscle fibers cycle between the contraction phase, in which myofibrils actively shorten, and the relaxation phase, when the abdominal wall's natural tension pulls the fibers back to their original length. If this tension is lost, the resulting imbalance causes the muscle to become fixed in a contracted state that is resistant to appositional traction. Open abdomen complications include lateralization of all abdominal wall muscles and buckling of the rectus abdominis muscles causing a diamond-shaped defect. Rectus abdominis buckling carries inherent problems, since when these muscles contract, they increase the gap width of the defect and exaggerate the characteristic diamond-shaped opening in the midsection of the wound, further compromising the function of the obliques and the transverse abdominis muscles. These oblique and transversus abdominis muscles have broad insertions and work together to provide functional support. Disruption of the linea alba in open abdomens results in lateralization of the abdominal wall muscles, bucking of the rectus abdominis, and compromised function of the oblique and transversus abdominis muscles. Such unopposed forces lead to widening of the opening and lateralization of all the abdominal wall muscles. Fascial retraction of the abdominal wall can begin in as little as 3 days. This is an important surgical concern and may lead to significant complications. If left open, a permanent defect results over time requiring alternative treatments, including surgical insertion of mesh or component separation. Many complications may arise if loss of domain occurs, including respiratory compromise, fluid loss, bowel perforation, ventral hernia, infections, prolonged hospitalization, and increased treatment costs and social burden. The AbClo abdominal wall closure system consists of a circumferential dynamic retainer, or CDR, that wraps around the torso, the tensioner gauge system, and two rectus muscle splints, RMSs, that are placed on either side of the wound, each of which contain a silicone underpad, a crossbar and locking strip with locking buttons that hold the CDR snug, two tensioners with their associated tensioner tabs and cleats, and tensioning dials that allow for adjustment. The AbClo system works by splinting the rectus muscles, preventing flexion of these muscles while maintaining parallel fascial margins. Other technologies apply traction to only the rectus abdominis muscles, which insert into the linea alba. By encompassing the torso circumferentially with the CDR, the AbClo system provides critical support to the anterolateral muscles, returning them to their near-normal state. Placed early after surgery, the device exerts appositional tension that counters the natural retraction of the anterolateral muscles and prevents the muscles and fascia from becoming fixed in a retracted position. Loss of domain is prevented by appositional tension that engages the obliques and transverse muscles, thereby creating an opposing force to the intra-abdominal pressure, splints the rectus abdominis muscles and provides gradual traction on those muscles toward the midline, and prevents lateralization of all abdominal wall muscles. The non-invasive design of AbClo eliminates the need to penetrate the skin or fascia, thereby preventing tissue damage. With approximation of the fascial edges, the AbClo facilitates delayed primary closure without mesh or component separation. Position the circumferential dynamic retainer, or CDR, around the patient's torso, centered on the spine, leaving a free end on each side of the patient. Position the rectus muscle splint, RMS, approximately 2 centimeters from the fascial edge with the tensioning dial edge adjacent to the fascial defect and parallel to it, with the outer edge aligned with the anterior axillary line. A protective skin layer may be used under the rectus muscle splint if desired. Open the crossbar to allow insertion of the CDR into the opening between the crossbar and RMS. Feed the CDR through the opening on both sides of the fascial defect. Grasp the leading edge of the CDR and apply tension by pulling firmly until resistance is met while maintaining both RMS in the correct position. Fold the CDR back posterolaterally and gently push it against the locking strip's hook and loop system to secure it in place. On both sides, push the locking buttons down into their mated slots in the RMS until they click into place. Confirm proper placement and parallel alignment of the RMS approximately 2 centimeters from the fascial edge. Ensure the tensioner gauge system is reading, at rest and without any external pressure on it, in the blue range. If it is not in the blue range, please follow the steps in the instructions for use guide for adjusting the resting tensioner gauge before continuing. Then place the tensioner gauge system's balloon section down the center of the fascial defect in parallel with the RMSs. Ensure the tensioner gauge system isn't interfering with any TAC or temporary abdominal coverage device covering the fascial defect. Simultaneously advance both RMS devices towards the fascial defect, creating tension on the CDR. Maintain each RMS parallel to the fascial defect edge and approximately 2 centimeters, a thumb's width, from it. While holding the RMS securely in position, pull up on the most proximal tensioning dial, releasing the tensioner for extraction. Pull the tensioner across the fascial defect and position it in the corresponding cleat on the opposite RMS. Push down on the tensioning dial to engage it and rotate clockwise to wind the tensioner until taut. Repeat the same process on the lowermost tensioning dial, then continue alternating top and bottom for the remaining dials. In unison, tension both sides equally while maintaining parallel alignment with the fascial defect. Ensure that each tensioner tab remains secure in its cleat. Apply tension equally until the gauge on the tensioner gauge system reads in the green zone. Fluctuation is expected with patient's respiratory movements. The gauge reading should stay in the green zone on patient exhale. If the gauge reading exceeds the green zone and enters the red zone, gradually loosen the tensioners equally by pulling up on the tensioning dial to release them until the gauge returns to the green zone. Ensure the tensioning dials are pushed down and engaged after returning to the green zone. Retensioning of the dials may be required. Note that the sequence of tensioner installation and tightening should keep the RMS parallel. Inspect the RMS for tautness, placement, parallel position, and distance from the fascial defect. Velcro tensioner gauge to the CDR for safe placement. Place gauze protection underneath the tensioners to prevent damage to the temporary abdominal coverage material, ensuring that the gauze protection does not interfere with the tensioner gauge reading. Monitor the tension gauge to ensure the gauge is in the green zone. If the gauge is in the red zone, decrease the tension. If the gauge is below the green zone, increase the tension by equally tensioning the RMS with the tensioning dials. Note that the sequence of tensioner installation and tightening should keep the RMS parallel. Reassess AbClo RMS placement and tension per institutional protocols for intra-abdominal pressure. AbClo is designed to perform gradual approximation of the fascial defect. Therefore, complete fascial reapproximation from the outset should be avoided. Given that lateral fascial retraction occurs in as early as 3 days, best results with the AbClo are obtained with early application. Apply the AbClo early, the sooner the better. AbClo may be used with any temporary abdominal closure device and is always placed on top of the temporary abdominal coverage material with or without negative pressure wound therapy. Do not use AbClo over unprotected viscera. The AbClo closure system has revolutionized the management of open abdomens. Additional surgeries are avoided, and delayed primary closure can be achieved sooner, resulting in better outcomes for your patient and their families. Choose the innovative AbClo for dynamic gradual fascial reapproximation, expedient primary fascial closure, non-invasive technology, loss of domain prevention, continuous abdominal access, fascial edge preservation, and bedside application. To find out more, please visit our website at abclomedical.com.